We're going to go ahead and begin. I'd like to thank everyone for coming to our echo today. This is the Urea Cycle Disorders Echo. It's brought to you today by the National Urea Cycle Disorders Foundation and the Urea Cycle Disorders Consortium. This is session 1 in a 4-part series. And before we get started, if you could scan the QR code, you can also find a link in the chat to sign in to the Echo sign in. And we'll pause for just a minute or two and allow everyone to sign in. Okay, we'll go ahead and get started. The National Urea Cycle Disorders Foundation has a mission, and we believe that saving and improving the lives of children and adults with urea cycle disorder is paramount. We believe that this 4-part essential series will get us closer to effectively diagnosing, rapidly treating, and one day our mission for a cure for UCDs. So thank you for being here today, and thank you for sharing in our commitment to our community. As we get started, I want to go over the agenda for today. Our first 5 minutes will be introductions and some housekeeping. There'll be a 40-minute didactic presentation by our subject area expert, Dr. Lindsay Burrage from Baylor College of Medicine. We'll follow that with a 10-minute discussion, a 15-minute for 2 case studies, and then we'll end our session today with a 20-minute group discussion. We'd like to welcome everyone and get to know you. So in the chat, if you could introduce yourself with your name, your organization, and your location. Our hope is that this session will continue. Everyone will join us for session 2, 3, and 4. That way we can get to know you. While you're entering your information into the chat, I'll just cover a few of the housekeeping items. If possible, when we do our discussions, if you could keep your cameras on, I think that will help for us to get to know each other. Our session is being recorded today, and it'll be made available at nucdf.org/echo. Echo is intended for educational purposes only. Presenters cannot provide any individual medical advice. We'll break for questions at the end of each session. And to receive your CME credit, please remain in the session, and we'll have a link at the end of the presentation. My name is Teresa Warner. I am a parent of a UCD patient and the executive director of NUCDF. Jill Williams is our deputy director, and she is manning the chat. So if you have any questions, she'll be able to help you. I'm going to pass it along to Dr. Sandesh Naganami at Baylor College of Medicine and the co-PI of Urea Cycle Disorders Consortium to do our next introduction.
Thank you, Teresa. I'm Sandesh Nagamani, and I'm representing the National Urea Cycle Disorders Foundation, the Urea Cycle Disorders Consortium, and I'm talking on behalf of Dr. Andrea Grokman, who's on the audience today, and myself, to tell you that it's a distinct pleasure for us to introduce our inaugural speaker for the UCD Teleecho series. This will be Dr. Lindsay Burrage. I've known Dr. Burrage for 14 plus years. Dr. Burrage completed her MD PhD from Case Western Reserve University and her pediatric residency at the Rainbow Babies and Children's Hospital, Case Medical Center, both in Cleveland, Ohio. We were extremely lucky that she chose to come to Baylor College of Medicine in Houston, Texas, for her medical genetics residency and medical biochemical genetics fellowship, after which she stayed on as faculty. Currently, Dr. Burrage is a tenured associate professor in the Department of Molecular and Human Genetics at Baylor College of Medicine, and she's an attending clinical geneticist and clinical biochemical geneticist at Baylor College of Medicine affiliated hospitals, including Texas Children's Hospital, as most of you might know, is one of the largest children's hospitals in the country. She is a star physician, scientist, educator, and administrative leader at our institute. She serves as a multi-PI for the Center for Precision Medicine Modeling and co-lead for its clinical section. The CPMM is one of only 3 such centers in the United States. She's the co-lead for the sequencing analysis team of the Undiagnosed Diseases Network at Baylor College of Medicine. She's a lead investigator and is on the leadership of the Urea Cycle Disorders Consortium. In her lab, she studies mechanisms that underlie clinical manifestations of inborn errors of metabolism. Most importantly, she's an outstanding educator and serves as Associate Residency Program Director for our Medical Genetics program and has won the Best Educator Award from residents consecutively for many, many years in the recent past that I can remember. And she's a very dedicated physician who takes care of children and adults with IEM and genetic disorders and skeletal disorders. And we're delighted that she's going to kick off our series. Dr. Burrage, it's all yours.
Thank you, Dr. Nagamani. I'm going to go ahead and share my screen. There you go. Can you see my screen okay?
Mm-hmm.
Yes.
Okay. I'd like to begin by thanking Dr. Nagamani for that kind introduction and thanking the NUCDF leadership as well as Project ECHO for having me today to talk to you about urea cycle disorders recognition and testing. I have no financial conflicts of interest. It is important that I mention that I do serve in a volunteer capacity on the medical advisory board of the National Urea Cycle Disorders Foundation, and I'm a member of the Urea Cycle Disorders Consortium. I also receive funding from the NIH to support my work in urea cycle disorders. The objectives of today's talk are to recognize the symptoms of high ammonia levels in children and adults, discuss the challenges of recognizing urea cycle disorders, review standard collection and processing of ammonia levels, and discuss testing strategies for diagnosing this group of disorders. I'm going to begin with a multiple choice question just for us to think about at the start of the talk, and then we'll revisit this question at the end of the talk. Which of the following is a possible presentation of a urea cycle disorder? A 3-day-old male infant with lethargy and vomiting. B, a 4-year-old girl with acute liver failure. C, a 4-year-old boy with spastic diplegia and developmental delays. D, a 21-year-old female with anxiety, depression, and psychosis. And E, a 36-year-old female with hyperammonemia after childbirth. So before we jump in and talk about urea cycle disorders, I think it's important to step back and talk a little bit about the larger group of inborn errors of metabolism. Inborn errors of metabolism, or IEM for short, are genetic disorders that result from a block in a metabolic pathway. These disorders typically involve enzymes in the metabolic pathway that become deficient and cause upstream metabolites to accumulate and downstream metabolites to be deficient. Or in some cases, they involve transporters of key metabolites that are important for a metabolic pathway to function properly. Inborn errors of metabolism can present in a wide variety of ways and at varied ages. And so it's important for healthcare providers who take care of both children and adults to be familiar with them. And why is that? Well, there's many reasons to learn about inborn errors of metabolism like urea cycle disorders. First, it's important to appropriately manage newborn screens. The newborn screening program is a program that screens newborns in the newborn nursery for treatable disorders prior to the onset of symptoms so that early therapy can be initiated. And this process occurs by collecting blood spots, typically from the heel of infants, at 24 to 40 hours of life. And these blood spots are placed on filter paper and sent off to central laboratories for processing. And when one of these screens comes back positive for a possible diagnosis of an inborn error of metabolism, the pediatrician, the neonatologist, or perhaps family medicine physician will be notified, and folks need to recognize how to act. In addition, emergency medicine physicians, as well as pediatricians and internists, need to be able to recognize acute emergency presentations of these disorders and provide appropriate primary care to individuals with inborn errors of metabolism. In addition, a subset of individuals with inborn errors of metabolism will need surgeries, and in many cases, they need to have very specific perioperative care to keep them safe before and after procedures. And so an understanding of the diagnosis can help facilitate the provision of appropriate care for them. And then many of our patients do require subspecialty management, and it allows folks to provide disorder-specific management in a subspecialty clinic. So now we can jump into urea cycle disorders, which are a subgroup of inborn errors of metabolism. The UCDs, for short, are a group of inborn errors of liver metabolism that impact approximately 1 in 10,000 people. The prevalence of UCDs is not exactly known because we suspect that there are patients who have these diagnoses and it's unrecognized. These disorders can present in infants, children, and adults, and individuals with UCDs, like other inborn errors of metabolism, can be encountered in every medical specialty. Before we jump into the individual disorders, it's important first to step back and talk a little bit about the urea cycle itself. The urea cycle is a series of 6 enzymes, each of which are shown here in blue, that are present in the liver, and their main job is to take nitrogen from amino acids in the protein that we eat and convert it to a safe waste product called urea. This generation of urea allows us to safely excrete waste nitrogen from protein that we eat. And in this process, it allows for the elimination of about 40 to 50% of dietary protein that's not needed for growth and maintenance. And it allows for the generation of intermediates, such as arginine, that are important for other metabolic pathways. Now, we like to divide the urea cycle up into the proximal disorders, which includes the first 3 enzymes. These first 3 enzymes are located within the mitochondria, and the distal disorders, which are the other 3 enzymes that are located in the cytoplasm shown here. When one of these 6 enzymes is deficient, the urea cycle cannot make urea as efficiently, and as a result, waste nitrogen builds up, and when it builds up in the form of ammonia. And ammonia is a neurotoxin that interferes with brain metabolism and neurotransmission. And elevated ammonia levels can cause astrocyte swelling, brain edema, and herniation that can ultimately lead to coma and death if untreated. So hyperammonemia, or high ammonia levels, are a life-threatening manifestation of urea cycle disorders. Now, these high ammonia levels can manifest in many different ways, and the specific manifestations can depend on the age of the patient. So for infants with high ammonia levels, they may present with symptoms like poor feeding, lethargy, not acting like self, difficulty waking up, respiratory distress, vomiting, seizures, or coma. In fact, these symptoms of high ammonia levels may mimic neonatal sepsis or neonatal infections. And such, if you're working up a patient for neonatal sepsis, you should also consider checking an ammonia level, because these can look very similar, and some patients could have both. Now, for our older children and adults, high ammonia levels may present with chronic intermittent vomiting, headache, lethargy, altered mental status, avoidance of dietary protein in the diet, behavior changes, nausea, confusion or disorientation, anxiety, seizures, or coma. And in fact, the symptoms of high ammonia levels in older children and adults can sometimes even mimic psychiatric illness, such as bipolar disorder or schizophrenia, or drug and alcohol intoxication. And so if you're evaluating an older child or adult with altered mental status, or you're concerned about psychiatric illness or drug and alcohol intoxication, it's important to consider checking an ammonia level in these situations. Now, if you're checking a blood ammonia level, it's important to make sure that the sample is processed appropriately, because sometimes poor handling or improper or delayed processing of blood samples for ammonia levels can lead to a false elevation in the result. And then it's hard to determine if the blood ammonia level is really high or not. So to get and ensure accurate blood ammonia levels, it's important to use a free-flowing blood sample, preferably collected without a tourniquet, and to place that sample immediately on ice and bring it immediately to the laboratory where it will be processed so that results are available in about 30 minutes. In fact, when I review ammonia levels, I always try to double check the collection and result time to verify timing. And if you're able to follow this process each time you check an ammonia level, you can be assured that it's more likely to be an accurate result. It gets confusing when you get a high level and it may not have been processed appropriately, and then you don't know whether it's really a true elevation or a false elevation. And given the life-threatening nature of blood ammonia, you have to repeat it immediately and have to take it seriously until you sort that out. So it's best to collect the sample appropriately and make sure it's run in a lab immediately so that you know you can have confidence in the results. And again, as ammonia is neurotoxic, high ammonia levels require emergent treatment. So when you do get an emergency level, you need to act fast. So today we're focusing on urea cycle disorders as one of the main topic of our talk, but there is a differential diagnosis for elevated ammonia levels that includes other inborn errors of metabolism. One example would be some of the organic acidemias. Liver disease, especially we see this often in adults, can cause high ammonia levels, but also liver bypasses like a portacable shunt can also cause high ammonia levels. In neonates, a severe herpes simplex infection can cause very high ammonia levels, and so it's important to consider in the differential diagnosis. Other causes can include infection with urease-positive bacteria, fibrolamellar hepatocellular carcinoma. Certain medications like valproic acid and L-asparaginase can do it. And of course, we already talked about on the previous slide that sample collection or handling error can cause it as well. And this list is not completely exhaustive, as there are other possible causes as well. So when you're evaluating a patient with a high ammonia level and you're trying to determine if they might have a urea cycle disorder, you could also consider some of the risk factors for high ammonia level in UCDs and ask about these as you collect your history from the patient. Some of the risk factors for elevated ammonia levels in UCDs include fasting or skipped meals, a high dietary protein load, and this is because the amino acids from the protein are the source of nitrogen that causes ammonia to build up, since it can't be processed as efficiently. Intercurrent illness that can cause a patient to become catabolic or cause catabolic stress. Similarly, rapid weight loss, poor food intake, menses, vomiting, surgery, the postpartum period, as well as medications like steroids or valproic acid, infections, and other stressors, all in some cases precede the high ammonia level and might give you a clue. However, Although these risk factors can trigger the initial presentation in a patient with a UCD or a metabolic crisis in a patient with a known diagnosis, we don't always have one of these obvious trigger in our patients. So the absence of one of these triggers certainly doesn't rule out a UCD, as some individuals with a UCD may simply have no obvious trigger that we can identify for their elevated ammonia level. Other additional history that might be supportive of a possible urea cycle disorder diagnosis includes unexplained and intermittent vomiting, or protein avoidance, because the body starts to avoid protein because it recognizes this as the source of the nitrogen that causes the body to feel unwell and get sick. Intermittent, unexplained elevations of hepatic transaminases, intermittent altered mental status, unexplained psychiatric symptoms, and in some cases, you may have some clues on family history. However, a negative family history never ruled out a UCD, as some patients are the first patient in their family to have the diagnosis. So elevated ammonia, what's next? So certainly if the cause for the elevated ammonia is unclear and you suspect a urea cycle disorder, it's important to contact your local metabolic genetic specialist team for advice on immediate management and advice on making a clear diagnosis. And this should be done as quickly as possible. As we already mentioned, elevated ammonia is a life-threatening emergency. So when you suspect a urea cycle disorder, how do we narrow down which diagnosis it may be? So as I mentioned before, we like to divide up the urea cycle into the proximal urea cycle and the distal urea cycle. The proximal urea cycle disorders involve the three proximal enzymes: OTC deficiency, CPS1 deficiency, or carbonyl phosphate synthetase 1 deficiency, and NAGS deficiency, or N-acetyl glutamate synthase deficiency. These, in addition to all being localized within the mitochondrial matrix, these three disorders also have in common that they tend to be associated with a low citrulline, because all three enzymes sit upstream of the metabolite citrulline. In addition, these three disorders are not covered by all state newborn screening programs. And it's really important to remember this, because the only way you can make a diagnosis is, in these cases, is to recognize it and check the ammonia and recognize the urea cycle disorder. So of the three proximal urea cycle disorders, OTC deficiency is by far the most common, and it's also X-linked, and that is a unique feature amongst all of the 6 main urea cycle disorders. And so we'll spend a little time, given that it's the most common, we'll spend a little time talking about OTC deficiency. So as I mentioned, OTC deficiency is the most common UCD with an estimated prevalence of about 1 in 15,000. Again, this is an estimate because we suspect there are folks with OTC deficiency who don't recognize that they have it. This disorder is associated with X-linked inheritance, and as a result, it's typically associated with a severe early onset presentation in males, because males only have 1 X chromosome. But this is not always the case, and there are some individuals who have a late onset presentation in males because of a milder mutation. Females, on the other hand, have 2 X chromosomes, and as a result, they can have a wider range of presentation, from early onset severe hyperammonemia to apparently asymptomatic but still at risk for high ammonia levels. In addition, females, and rarely males, may also present with an acute liver failure. So here's an example of a pedigree, or a drawing of a family that might provide some clues to a diagnosis of OTC deficiency. So if you're evaluating this patient here with the neonatal hyperammonemia, if you ask about the family history, you might find that there's a history of multiple male infant deaths of unclear cause, or you might find that there are some females in the family who maybe avoid meat, maybe they have some psychiatric symptoms, maybe they have some unexplained vomiting, maybe a liver failure of unclear cause. And if you do find this information, this can be helpful because it might suggest a diagnosis of OTC deficiency. And certainly in this example family, one might expect that if you did genetic testing and were able to test all the individuals, you might find that indeed the two unexpected early male deaths were positive for OTC deficiency, and some of the females with more nonspecific symptoms may be carriers. However, so certain family histories may give you a clue to the diagnosis of OTC deficiency, but in other cases, the patient that you're seeing may be the very first person in the family to have the diagnosis due to a new variant, or perhaps the more nonspecific symptoms may be harder to tease out. So having a family history of symptoms may help you, but if you don't have a family history for your patient that's suggestive of a UCD, you still have to consider it in the differential diagnosis because not every patient will have a family history that's helpful. So if we move from the proximal urea cycle disorders to the distal urea cycle disorders, here we have the three enzymes that are located within the cytoplasm. ASS1 deficiency or arginosuccinic acid synthase deficiency or citrullinemia is the first enzyme deficiency. The second is ASL deficiency or arginosuccinate lyase deficiency, also called arginosuccinic aciduria. And arginase 1 or arginase deficiency, also called hyperargininemia, are the three of the distal disorders. Now, unlike the three proximal disorders that we talked about already, the three distal disorders are typically included on state newborn screening panels. And so patients may be diagnosed even before the onset of symptoms. However, it's important to remember that newborn screening is a screen, not a diagnostic test, and it may not be perfect. And so you may also detect these disorders in patients who had a previous negative newborn screen, and that's true for all newborn screens. So first, citrullinemia or ASS1 deficiency. This disorder is characterized typically by very high elevations in citrulline, and the most common presentation is high ammonia levels. And this high level of citrulline is because it sits right upstream of the enzyme that's deficient. There are some milder forms of citrullinemia that may have a milder elevation, but typically the levels are quite high. ASL deficiency, which involves the next enzyme, is characterized by milder elevations of citrulline, as well as the presence of a metabolite called ASA or arginosuccinic acid. The finding of ASA is pathognomonic for ASL deficiency because we typically don't see elevations of ASA in any other diagnosis. And then in addition, we'll see a low arginine like we do in citrullinemia. ASL deficiency is unique amongst the urea cycle disorders because patients seem to have a higher risk for hepatic fibrosis. A subset of patients seem to have high blood pressure, and patients may have neurocognitive impacts beyond what is expected from the hyperammonemia alone. In addition, some patients with ASL deficiency may not present with high ammonia levels, so it's important to recognize that as well. And the same is true with arginase deficiency. Arginase is, again, the very last enzyme of the cycle, and arginase deficiency is the only urea cycle disorder that's associated with high levels of arginine it's the metabolite right upstream of the enzyme that's deficient. And like ASL deficiency, all patients may not present with high ammonia levels. But what's unique about arginase deficiency is that the patients can present with spastic diplegia, developmental delay or intellectual disability, and or seizures in the absence of high ammonia levels. And this is because the high arginine produces neurotoxic biochemicals called guanidino compounds that lead to the spastic diplegia, developmental delay, intellectual disability, and seizures, even when high ammonia levels are present. Now, we focused on the 6 primary urea cycle disorders, but there are other urea cycle disorders, often called secondary urea cycle disorders. And these include citrin deficiency, hyperornithinemia, hyperammonemia, homocitrullinuria syndrome, lysiniuric protein intolerance, as well as others. And these secondary urea cycle disorders typically involve shuttles or transporters that bring key amino acids or other important metabolites to the proper location in the cell so that the urea cycle can function appropriately. So now that we have the suspicion of a urea cycle disorder and we have reviewed the 6 primary urea cycle disorders, what kind of biochemical testing can we do in order to determine which of the disorders is the likely cause? So first, we can do plasma amino acids, and that's because plasma or serum amino acids can detect some of the key urea cycle intermediates that can help us distinguish the various urea cycle disorders. In particular, we can measure citrulline, ASA, as well as arginine. And the pattern of citrulline and arginine elevations or the presence of ASA can help us narrow down the differential diagnosis for a particular UCD. So for instance, as we mentioned, for the proximal disorders, we'd expect to see a low citrulline and a low arginine. In contrast, with citrullinemia, we would expect typically to see a very high citrulline and a low arginine, although there are some milder forms. In ASL deficiency, we would see a milder elevation of citrulline, the presence of ASA, which is pathognomonic, and a reduced arginine. And then an arginase deficiency is the one disorder where we see elevations in arginine. The one urea cycle disorder, I should clarify, with elevated arginine. In addition, we often will see an elevated glutamine because glutamine has multiple nitrogens and it can reflect a high nitrogen load. And so we often see elevations of glutamine, and we may also see other abnormalities, but these are the ones that can help us narrow down the diagnosis. Now, in addition, we can also measure a metabolite called orotic acid. Orotic acid is a metabolite that's produced from carbonyl phosphate, which sits right upstream of OTC. We typically will see elevations of orotic acid in the urine in patients who have OTC deficiency, but we can also see it in other distal urea cycle disorders because this metabolite does derive from an upstream metabolite. In contrast, typically, we don't see elevations in the other 2 proximal disorders, NAGS and CPS1 deficiency. So sometimes having a high orotic acid can help us clue into a urea cycle disorder diagnosis, and sometimes it can help us narrow down as well. So in addition to plasma amino acids and urine orotic acid, we sometimes will also measure urine organic acids. Urine organic acids can sometimes show an elevation of uracil that might give us a clue of a urea cycle disorder. But it's important to mention that these are typically not the best for detecting the orotic acid, and sending a dedicated urine orotic acid level is the best way to go about detecting and quantifying that metabolite. We sometimes will measure urine amino acids, especially if we're considering some of the secondary urea cycle disorders. And if we're evaluating a newborn, it can often be helpful to contact the newborn screening lab. Even if the newborn screening result is not available, if you contact the lab, they're sometimes able to give you a preliminary result that might help you narrow down the diagnosis. But I think it's important to mention that the tests here all take hours, days, weeks to come back, depending on where you are and where you're sending your samples to. And so it's important not to wait for one of these results to come back before treating the high ammonia level, because the high ammonia, again, is an emergency. We'll often start treatment while we sort out the specific diagnosis. Now, the newborn screening is unique in that patients may present to you asymptomatically with an abnormal newborn screen, because the result in some cases may come back before the patient has signs or symptoms of a UCD. In those cases, it's important to evaluate the patient urgently so you can make sure that the patient is safe and not having signs or symptoms of a high ammonia level and confirming a normal ammonia level. And in these cases, we recommend that you follow the American College of Medical Genetics and Genomics ACT sheets, or ACT sheets. These are available online, and they provide an algorithm for managing an abnormal newborn screen for UCDs as well as for other disorders. And at the same time, it's important to urgently contact your local metabolic genetics specialist. One of the benefits of newborn screen is it allows us to detect these patients early and start treatment right away, but we need to work together to do that as soon as possible to prevent complications. So in addition to our biochemical testing, genetic testing can be done to confirm a molecular diagnosis. This testing can take many forms. Oftentimes, if we have been able to narrow down to a specific diagnosis, we might send single gene testing. In other cases, we might send a panel, especially if we can't narrow down to a specific diagnosis. And these will include a panel of genes that are associated with urea cycle dysfunction. In some cases, acutely in the hospital, in patients who are quite sick, we may even send exome sequencing or whole genome sequencing, especially if the diagnosis is not clear, and also if we're able to get a very quick answer. And in some cases, we can get a quicker result from exome and whole genome sequencing than we can from some of the single gene testing or UCD panels. Confirmation of a molecular diagnosis is important for genetic counseling for families and for testing of at-risk family members. And so it's important if we're able to get genetic testing to offer it to families and pursue it. So to conclude, today we focused on the recognition and testing for high ammonia levels and an overview of the urea cycle disorders. Our conclusions are that ammonia levels should be considered in neonates with sepsis and in older children and adults with altered mental status, and some of the other features that we discussed. Samples for measurement of blood ammonia should be collected and processed appropriately so that we can ensure accurate ammonia levels. And we discussed the different factors that can contribute to a false elevation and how this can really make it confusing. And when we get an elevated ammonia because it's an emergency, we can't just assume it's a false elevation if it's not collected appropriately. So appropriate collection can help give you confidence in interpreting the levels that you get back. The initial presentation of a urea cycle disorder can occur at any age, neonates, infants, children, and adults. A diagnosis of a UCD can impact immediate management of the patient, but it can also impact other family members and allow us to test other at-risk family members so that they can get treatment right away. And again, we can't emphasize enough that high ammonia levels are an emergency and should be treated as such. So if we end the talk kind of back where we started with the initial multiple choice question, which of the following is a possible presentation of a urea cycle disorder? A, being a 3-day-old male infant with lethargy and vomiting. B, a 4-year-old girl with acute liver failure. C, a 4-year-old boy with spastic diplegia and developmental delays. D, a 21-year-old female with anxiety, depression, and psychosis. And E, a 36-year-old female with hyperammonemia after childbirth. I hope you come back to this question and recognize that any of these scenarios, A, B, C, D, or E, could all represent a patient with a urea cycle disorder. And so with that, I'm happy to open for questions and discussion before we move on to the case presentation.
Thanks a lot, Dr. Burrage, for that excellent talk. And I will be sort of assisting with the chat questions. So there are two questions that have come from Matthew Lemming. I'll read both of them out to you, and then you can answer each one in the order you choose to. The first one is, how does a tourniquet affect ammonia levels? And the second question is BUN, which is blood urea nitrogen, significantly lower in individuals with UCDs?
So I'll tackle the second one first. So for the BUN levels, they can be low BUN levels can be a clue in patients that they have a urea cycle disorder. It's not perfect though, and there are a lot of other factors that can contribute. And so I don't want to say for certain you have to have a low BUN or the BUN has to be a certain level, but it certainly can be a clue. Obviously, it's measuring blood urea nitrogen, and that's where the urea is coming from. But a variety of factors, including fluid status and others, can impact it. As far as a tourniquet can a poorly collected sample. So a sample that's a difficult blood draw with or without a tourniquet can lead to a false elevation. There are some patients that need a tourniquet to do the collection, and if you absolutely need one, sometimes folks are able to get a good free-flowing sample with a very loose tourniquet. But if it's tight and really difficult to collect, you're going to increase your chances potentially of a false elevation. So that's why we typically would say avoid a tourniquet if possible.
Thank you. Any other questions? If you are shy to put it in the chat, please feel free to unmute yourselves and ask the question. So while others are getting to theirs, one of the important things you brought about was with newborn screening. And if a primary care physician who does not have domain expertise in this were to get a positive result, what do you suggest would be the immediate things that they have to do? You did talk about ACMG act sheets. Would you want to just briefly let people know what your approach is to such questions?
Sure. I think you want to do a few different things. One, you want to contact your local metabolic specialist that works with you on newborn screen so that you can get their advice, but evaluating the patient immediately to make sure that they are safe, because they could be at home with a high ammonia level that hasn't really been maybe the family hasn't picked up the symptoms yet, or the symptoms are just starting. So you want to make sure they're evaluated. We typically will check an ammonia level and start the diagnostic process. So to determine whether the screen truly indicates a UCD by doing some of the testing that we discussed. All of this is outlined on the act sheet. And so they're a really helpful resource, but you should always call for help. So call the metabolic specialist that's local to you and have them work through it with you. But this is certainly not something that you want to wait overnight or wait over the weekend for, because the patient could be at home with a high ammonia level and it just not have been recognized yet. And time is brain, so you want to get them in and treat them if that's the case as soon as possible.
Any other questions? If not, we can move to the case discussions that Dr. Burrage will have. One final question. Again, in the hospital, if you get a pneumonia, there are a lot of variables, as you just alluded to, for having a high ammonia. Sample draws, time the sample sits on the ward before what is your approach to have a checklist to make sure that this is truly elevated ammonia? And what is your approach to getting a repeat test if you think that this is spurious, right? We have to balance what we think is spurious versus how we act. So can you give a practical sort of approach to this that you follow?
Sure. So, I think kind of considering the factors that we outlined in the slide, making sure that your phlebotomists or the folks who are drawing the blood are educated about the proper way to collect the sample and the importance of having ice ready available for the sample, and the importance of transporting the sample to the lab and ordering it within a lab that can process it on site. Certainly, if the blood has to travel, that adds time, and that can lead to spurious elevation. Certainly, once we have a diagnosis of a urea cycle disorder, we educate our families about this as well, so that our families can help us advocate for the proper handling of the sample. I have families who ask the phlebotomist, do you have the ice ready? Is it going to go to the lab right away? Those sorts of things to ensure that the results are accurate. Certainly when we get a result back, I do look at the collection time and the resulting time, but the challenge is that if you have an elevation, you have to act on it. And so, certainly immediately assessing the patient and getting a repeat level is warranted, because you don't know for certain if the elevation is real or if it's due to spurious lab collection. So it's advisable to try to ensure proper collection ahead of time so that you can have confidence in the results.
Dr. Burrage, there's another question from Teresa Warner. For neonates, when do the symptoms typically begin? And what if the newborn screen results have not yet been returned, but there are symptoms? How do you approach the immediate testing and the treatment in this scenario?
Yeah, the symptoms can occur, within the first day of life, the first 24 to 48 hours of life, and certainly the newborn screen is not back in those cases. So in those cases, somebody has to evaluate the patient and think about an ammonia level. And that's why it's important, because whether you're in the nursery or the NICU or a pediatrician's office, if you have a patient that comes in with the symptoms that we mentioned, what we often are trained to think about sepsis or infection. But in those cases, you have to think about the ammonia and get that result stat. And once you have that elevation, act on it, because it may be a few days before you have a newborn screen. And as we already alluded to, the proximal disorders are not covered by newborn screens in every state, and even where they are, they're not perfect. And so you have to think about the UCD in order to make the diagnosis, and you do that first by checking an ammonia level in patients who have this concerning presentation, and then you start treating it while you work up the diagnosis. That treatment includes promoting anabolism, cutting out protein temporarily, and potentially, depending on the elevation, starting certain medications and/or continuous renal replacement therapy. We have more sessions on treatment, so I'm not going to spend a lot of time on treatment, but I think the point is you need to act right away, because we want to get that ammonia level down as soon as we can.
So the next question from Jill Williams is something you probably get asked pretty often in the ER. How high does the ammonia level have to be to cause a damage in a child or an adult? And at what level should they receive treatment to lower the level?
I think the exact threshold, there are different thresholds that different centers use. The normal ranges vary based on age. So the normal range of ammonia levels for a neonate, a child, and an adult may be different. So it's hard to give very specific cutoffs, but I will say if in my patients who have urea cycle disorders, we aim to keep the ammonia level in the normal range as a treatment goal or management goal for them. So and different the thresholds for different treatments may vary by centers because not all centers will have access to all of the same treatment options, whether it be medications or renal replacement therapy, et cetera. And so I'm a little hesitant to give specific cutoffs because, again, they do vary by age. They do vary on what is available in your center and whether different treatments are available or not. But again, the ultimate goal, at least for management, is to have it normal.
So the next question is from Nina Janigal. And Nina asks, does blood sample have to travel on ice? In the United Kingdom, some key opinion leaders have said no ice is needed.
We certainly in our protocols do utilize ice, so I can't comment on protocols that don't. Certainly, if it's run immediately in the same location as the blood draw, maybe that isn't necessary. But again, our protocols are typically to place it on ice, so I can't comment on that.
So Jalal Knight Hamoud asks, what makes the difference between patients to treat with only diet and patients to treat with nitrogen scavengers? When should nitrogen scavengers be introduced?
So I think one of our future sessions will dive deeply into treatment and talk about the different treatment options regarding diet, nitrogen scavenging agents, amino acids, et cetera. But I think some of it is the severity of the patient, the treatments that are available, as well as their medical history and course are all factors that come into play as we make these decisions.
So one further question is, what's the role of genetic testing in diagnosis? In what situations would you order genetic testing, and what can you learn from the variants identified?
Yeah, so obviously, when you see a patient for the first time and you're evaluating them for high ammonia, you have to start treating the ammonia, and you don't necessarily wait for a specific diagnosis before you start treating them. Or you don't wait for genetic testing to come back before you start treating them. However, and you can get a clue to the specific diagnosis with the biochemical testing, although it's not always as easy as it perhaps I made it sound on the table. But genetic testing can help in a few different ways. One, it can help you identify the variants, which may be helpful for families as they're considering future pregnancies. It can also be helpful for testing other family members, in particular OTC deficiency, who may or may not be showing signs or symptoms. It can help us determine whether or not they have that variant, which is important because some of the milder affected females may not have biochemical testing that is clear cut. In addition, and there is data for some of the variants we identify as to whether or not they are associated with a severe or a late onset phenotype, so a more severe or a milder phenotype. And sometimes that can certainly help us as we're considering management. Obviously, we have to take into account the presentation of the patient in front of us, but having this additional information about whether or not a particular variant is associated with a milder late onset presentation versus a severe early onset presentation may help us make some decisions or help us plan and provide appropriate counseling for the patient.
Thank you. I do not see any other questions in the chat, so maybe we can move on to your cases.
Okay. So next we'll move on. We have two cases to discuss. Start with case one. So case one is a full-term baby boy who was born by spontaneous vaginal delivery and discharged home at about 24 hours of life after a newborn screen sample was collected. However, during the first 24 hours at home, he became fussy, was not eating well, and breathing was abnormal. He was taken to a local emergency center, and by that time, he was barely responding upon his arrival. He was evaluated in the emergency center for sepsis because there was a concern that he might have an infection, but ultimately he was transferred to a tertiary center for further evaluation and management. At the tertiary center, he had a lumbar puncture, cultures had already been collected at the other center, urine and blood, and he was continued on IV antibiotics given the suspicion for sepsis. However, he was ultimately diagnosed with high ammonia levels due to a diagnosis of citrullinemia and passed away 12 hours after arrival at the tertiary center. As a reminder, we talked about citrullinemia. Citrullinemia is one of the distal urea cycle disorders. For the most severe forms, which are the most common forms, the typical presentation is elevation in ammonia levels, just as this patient presented in the neonatal period. Very high levels of citrulline provides a provisional diagnosis, but at 24 to 48 hours of life, you wouldn't have that high citrulline yet. You may have it on a newborn screen, but if the newborn screen is collected at 24 hours of life, it probably wouldn't be back yet. So it wouldn't be until you actually got your newborn screen back or until you sent further diagnostic testing once you determined the patient had a high ammonia level that you could be clued into the diagnosis of citrullinemia in this case. So the learning points for the first case are that hyperammonemia and sepsis can have similar presentations in neonates. And so if you're seeing a neonate and you have the concern for sepsis because you're in the emergency center or you're a pediatrician in the nursery, you want to think about checking an ammonia level as well, because if you don't check it, you won't know and you won't be able to provide the appropriate therapy. As you're evaluating these patients, depending on their age, and depending on when the newborn screen was collected, you could consider calling the state newborn screen lab to determine if there's a preliminary result yet. So even if the newborn screen result's not yet available, you can call them, alert them that you're evaluating this patient and see if you can get a preliminary result as soon as possible. Because in a case like this, you might be able to find out that they have the elevated citrulline early in the course of your management. Likely not going to be back at the time that this baby presented though. So you likely would still have a pending newborn screen result when you're evaluating the baby for sepsis and need to get an ammonia level and start treating the baby before the result comes back. And again, it's important to highlight that newborn screening is simply a screen. It's not a diagnostic test. And so a normal newborn screen does not rule out a UCD. In this case, this infant had citrullinemia, which is included on newborn screen, but you could have a very similar presentation for OTC deficiency, for instance, and that is not included on newborn screens everywhere. And even where it is, it's not perfect. So questions or discussion on case one? If no questions, sorry, Dr. Nagamani.
No, I said there were no questions on the chat.
If no questions, I think case one is the kind of the typical presentation that we learn about in medical school, and those of us who take care of our patients, perhaps one of the more common presentations we see. The next case is a little bit different. So this is an older presentation, a 19-year-old healthy female who presents to the emergency center with altered mental status. At the time of presentation, Her AST and ALT, so transaminases, are elevated mildly, and she's given IV fluids for hydration. And over the course of several hours, her mental status improves, and she's ultimately discharged with instructions to have repeat AST and ALT levels done as an outpatient. And over the course of the several weeks and months, the repeat AST and ALT are done a few times, and they're mildly elevated, but then they subsequently normalize, and the patient's doing well. However, several months later, she's found unconscious in her bathroom. The EMS takes her to the emergency center where cerebral edema is noted. They do a full evaluation, including drug and alcohol screens, which are negative. And she's ultimately admitted to the intensive care unit and evaluated by neurologists, intensive care unit specialists, as well as others, but no cause for the cerebral edema is found. And the suspicion is that there perhaps was an intoxication event involving a drug that's not included on the drug screen. Brain death is eventually pronounced, and the parents choose to donate her organs. And the recipient of her liver ultimately dies from high ammonia levels. And at this point, the cause of death for the liver recipient is determined to be OTC deficiency that was acquired from the liver donor. And so if we go back to the urea cycle slide, OTC deficiency, as we mentioned, is one of the proximal urea cycle disorders. It is the most common, and it's X-linked. And you can see it here. These patients, if we have metabolites, they typically will show low citrulline and high orotic acid, but oftentimes they're coming to us with high ammonia level, and we don't have these results as a clue to their diagnosis just yet. So following this diagnosis, retrospectively, the parents report a history of protein aversion, and that as a young child, this patient avoided meat and high protein foods and had intermittent episodes of unexplained vomiting in childhood. No cause was found, and it would resolve on its own. Parents didn't think much of it. However, she never had known episodes of high ammonia level, but she never had an ammonia level check. So she didn't have it as she was growing up. She didn't have it in the emergency center either time she presented. But the suspicion is that she likely had high ammonia levels at these times. Ultimately, her diagnosis of OTC deficiency did facilitate genetic testing for other at-risk family members. And so it gave an explanation for her unfortunate death and presentation, but it also did help us diagnose. It helped the family have testing for at-risk relatives. So what are some learning points for case number 2? Case number 2 highlights how hyperammonemia can mimic drug or alcohol intoxication. In fact, that was the diagnosis that the suspected diagnosis for this patient before the recipient of the liver passed away from high ammonia levels. Elevated liver enzymes in the setting of altered mental status may be a clue of high ammonia levels. And so if you see that combination, consider checking an ammonia level. Severe high ammonia levels can cause cerebral edema. So if you're evaluating a patient with cerebral edema of unknown cause, check an ammonia level, because that might help clue you into the diagnosis. And then subtle signs in the history, as you're seeing a patient, hearing about protein aversion or unexplained vomiting can be subtle signs of high ammonia levels. And so it may be something that clues you into an underlying urea cycle disorder diagnosis. And with that, I'll leave you with case number 2. There's an awareness video that was put together by the National Urea Cycle Disorders Foundation and Zoe, the patient's family, and the QR code will lead you to that video so you can learn more about Zoe's story if you're interested. And I'll leave this slide up so folks can access that site if they're interested while we continue any discussion or questions about case number 2.
So Dr. Burrage, while people are putting their case 2 questions. Matthew Lemming again asks, for case number 1, your citrullinemia with hyperammonemia. Speaking of differential diagnosis, in case number 1, is sepsis the differential diagnosis most often seen in newborns?
If I'm understanding the question correctly, the signs and symptoms of high ammonia levels and sepsis overlap. Babies don't have a well-developed immune system, and they're at high risk for sepsis, and these are some of the signs and symptoms that they have, and they happen to overlap with high ammonia levels. So it's often what folks might be considering in their workup. It's often on the top of the list whenever you're evaluating a sick newborn. So it's important that if you're evaluating a patient for sepsis to consider checking an ammonia level as well, to be sure that that isn't contributing to their presentation.
So Jill Williams asked, why aren't ammonia tests considered more often in these situations, and what can we do to raise awareness among frontline clinicians? And in the true spirit of Teleecho, this is a democracy, so please feel free to sort of put in your responses in the chat as well. Dr. Burrage, do you want to take that, or?
Sure. I think sepsis is common, and it's more common than UCDs, and so folks tend to think of the more common explanation before they consider some of the more rare diagnoses. And that might be one of the reasons. And because of that, there are some hospital systems that do have alerts that pop up when a neonate is being evaluated for sepsis, to alert folks to consider checking an ammonia, because with a reminder, folks may then say, oh yeah, I need to add that ammonia level check, and they could potentially diagnose patients earlier by checking it right away as they're doing the initial evaluation. So that's one explanation, I think.
Do you mind if I add to that as well?
Yes, please.
So if the question again, Jill, was for the adult sort of scenarios, sometimes, as in this case, when you saw that the liver enzymes were elevated and the ammonia was a bit high, physicians could ascribe that higher ammonia just to the hepatic dysfunction and not immediately think of a urea cycle disorder, which again can have catastrophic consequences. I am also putting in the chat for your second question, what can we do to raise awareness for frontline clinicians? For those of you on the call today, there's a site, checkammonia.com, that basically was an NUCDF mission to make sure that what happened to Zoe does not occur again. Checking an ammonia is an easier test to do. So for your second question about frontline clinicians, I've put that in the link for the audience. We probably could go to your third illustration, Dr. Burrage, if you have one.
We have just the 2 cases today.
Wonderful. If there are any other questions regarding the talk today, please feel free to unmute yourselves and ask the question, or if you have insights that you would want to share, please do so on the chat as well. Jill, I will pass it on to you to sort of do the closeout.
Sure, thank you. Yeah, I would love to get broader answers. We've been running the Check Ammonia campaign for some time, and we still routinely hear from patients who have been missed on diagnosis. So we'd love to get broader input on what NUCDF as an organization could do to help make some inroads on solving that problem. And so anybody, please feel free to unmute and speak up.
I'll share. Hello, everyone. My name is Mary Reedy. I'm a clinical assistant professor at University of Buffalo School of Pharmacy and Pharmaceutical Sciences. I'm in an endowed chair position, and the donor has sort of a vested interest in metabolic genetics. And so through this role, I am able to educate healthcare professionals, as well as work in a clinical practice site. I teach an elective in rare genetic disorders at the school that enrolls clinical nutrition students, medical students, and pharmacy students. And I have a whole class actually showing Zoe's story and the importance of checking an ammonia level. And I developed a case, that assignment that the students do, where it's actually like a resident and that sort of reminded the team to check the ammonia in the emergency room. So I think one huge population would be to empower our new learners, because I think medical residents, medical students, sort of the incoming health professional society is the most likely to sort of sometimes think about these rare disorders because they don't have the biases of common things being common. And so maybe empowering our upcoming healthcare professionals would be sort of a good step.
I certainly agree. And I think we utilize Zoe's story quite frequently in our teaching endeavors here. And certainly it's posted on the NUCDF website for other folks to use as well, because I think it is this story, as well as cases similar to case number 1, are very important examples, and they're memorable for folks, especially in the training stages. And I do think it's an awareness issue. It's an awareness issue, especially for adult providers. I think in some part the way we do better with our pediatric providers, because folks consider inborn errors of metabolism disorders for pediatricians, but they're disorders for pediatricians and adult providers, and so increasing education there is important as well.
And I think even like gathering maybe from patients that are involved in the foundation, like who is the person that diagnosed you, right? And sort of seeing the spectrum where like, oh, well, it was my primary care, it was my neurologist, it was a hepatologist, it was someone in the ER, like who mentioned, let's check an ammonia. And I think sort of like empowering through the story of like, this is happening not just in genetics, it's happening in other avenues, I think is sort of like a powerful story as well, to say like how many patients get diagnosed through this avenue.
This is Teresa. Mary, I want to say thank you for all of those suggestions, and thank you for using Zoe's case. That was the whole idea, for a family to be so gracious to share the tragedy of the death of their daughter, but they knew that they would save lives. So knowing that it's being used to train students, that's exactly what the purpose is. And our Check Ammonia campaign is one step further. Our goal is to reach those frontline care providers, the emergency room physicians, nurse practitioners, pediatricians that don't normally think about checking ammonia. And so this ECHO, along with the Check Ammonia project, is our way of trying to put our arms around every avenue we can to just continue to say it over and over again, because we know that anytime someone thinks about checking ammonia, there's a potential to save a life. So thank you for that.
Yeah, thanks, Teresa. I agree. I mean, our goal is to make this a routine part of both medical education and medical care, and anything that we can do to push that goal forward, we want to try to pursue that. I went to a conference in January about transition to adulthood, And there's a very broad effort right now to improve that process for rare disease patients. And they're working with the National Quality Forum to set standards of care in place that, if they're successful, could potentially become, a core part of all medical care. So I mean, that's just one potential idea. Anything we can do, we would love to hear suggestions.
Well, I can say a little something. I'm a nurse. Maybe I'm not supposed to be on here, but my doctor invited me so I could learn. And I just wanted to thank Dr. Burrage because that presentation, I was worried at first, like this is going to be so above my head, I'm not going to get it. But you really explained it so well. Like I really learned a lot. And this, I haven't looked at Zoe's story, but I'm going to. But I mean, even nurses could be introduced to something like that because I mean, they're at bedsides too. And sometimes, not that they're diagnosing, but who knows? The more heads you put together, the better.
Absolutely.
Ms. LeBeau, I have two comments. One, we absolutely welcome nurses, all healthcare professionals. Again, this is a teamwork, and again, y'all are the first bedside healthcare providers who alert and notice things. And to your point, within our urea cycle disorders consortium, some of the lead research coordinators, sub-investigators are nurse practitioners. One of them, Saima Ali, who has been leading the UCDC studies at our site, who's on this call today, is an advanced nurse practitioner.
Yeah, one of our goals with launching this series is to create sort of a community of practice where people from the different disciplines can come together and problem solve on things like this and share information and educate one another. So we definitely welcome dietitians, nurse practitioners, emergency medicine physicians, pediatricians, mental health professionals who often are among the first to encounter patients with high ammonia levels, are all very welcome to join us.
May I also request all individuals who are on to get the word of mouth out about the series and the next series. Morgan Freeman once said that no matter how much you spend on your advertising, the only thing that makes a movie a success is word of mouth. If you hear it from someone that it is good, they will go, otherwise they won't. So please, we request you to please spread the word of mouth.
Yes, and if you have colleagues who might be interested in joining us, they are welcome to jump in. We're going to be posting the recording of this session on our website as well as on the Project Echo site. And they're welcome to watch that and join us for session 2 and the 2 sessions that follow that.
We want to thank everyone for participating today and give you a reminder of session 2, which is Tuesday, July 1st, same time. And the subject area experts will be Dr. Andrea Grotman and Dr. Sandesh Naganami. That will take us one step further into some of those questions that were asked and posed today that Dr. Burrage referred that we would have in our next session. I think that session 2 is very important to understanding, what are my treatment options? We have a QR code to your right. If you'd like to scan that, there's also a link in the chat for the evaluation form. We would appreciate that. We also, if you have a case or a question or a presentation that you would like to share, I have that on the next slide, but we will also email that out to all the participants today. Please feel free to share the information about our ECHO. Our goal is to create as much awareness as possible. And we greatly appreciate your participation today. I'll go ahead and move to the next slide so you can see this. We will be sending out an email tomorrow, and that'll have Any of the supporting documentation from the presentations today, along with a few of these links as well. And feel free to reach out to myself, Teresa Warner, or Jill Williams, and we'll provide our contact information. We would love for you to submit a case, a real world situation that's happened maybe in your clinic or one that you're aware of. And then here is the link to submit if you'd like to submit a case or a question. And there's also a link in the chat.
And Teresa, may I kindly request that you move one slide back? So
there you go.
Please have this QR code because you will need this for your CME. Once you're done with the evaluations, you can request CME. Please mark this QR code.
Yeah, and thank you to Dr. Burrage and Dr. Nagamani for your expert presentations and guidance during this session. We always appreciate your support and value your expertise and your ongoing support of our patient community.